Welcome to the platform Swiss Liver Patients Association Swiss HEPA. Today with the presentation by Dr. Benedetta Terziroli, Hepatocentro Ticino Lugano, and mother of 6 children on the topic Autoimmune Hepatitis. Welcome, Dr. Benedetta Terziroli.
Thank you, Karina, for this kind invitation and this opportunity that you gave me to talk to our patients on autoimmune hepatitis. So what is autoimmune hepatitis? There is a textbook definition of this liver disease, and this definition gives us the most important features of the disease. And these features are a chronic liver inflammation due to the immune system. Another important feature of autoimmune hepatitis is the female preponderance. The majority of the patients are female, and patients have high transaminases and IgG in blood. They also have autoantibodies, which we can measure in the blood. And if we take a liver biopsy, we see a peculiar form of inflammation called interface hepatitis. It is also very important to exclude other causes of hepatitis, particularly viral hepatitis. Another important characteristic of autoimmune hepatitis is its excellent response to steroid treatment. Why does autoimmune hepatitis arise? This is not completely understood. We know that there are risk factors, including a genetic predisposition, and this is mirrored by a positive family history, meaning that someone in the family of the patients often has autoimmune diseases, not only of the liver, but also of other organs. Gender is a risk factor because, as mentioned, the majority of patients are female, and age is also a risk factor since the disease rarely begins in when patients are older than 60 years. It is mostly a disease of the children or of young adults. Environmental factors are also very well-known risk factors, including viruses and drugs or other toxic agents. This is an example of a virus which can predispose to autoimmune hepatitis. In this case, it's hepatitis E virus. We took advantage of a small epidemic of hepatitis E, which occurred a few years ago in Canton Ticino. And we studied the blood of patients with acute hepatitis E. And we found that half of them had in their blood autoantibodies characteristic of autoimmune hepatitis, suggesting that hepatitis E virus infection can predispose to autoimmune hepatitis. This is very well known also for other viral diseases and particularly for hepatitis C. There are 2 forms of autoimmune hepatitis, type 1 and type 2, and the distinction is made based on circulating autoantibodies. Type 1 autoimmune hepatitis is characterized by positive anti-SMAS muscle and or positive anti-nuclear autoantibodies. What are autoantibodies? Antibodies are something good because they protect us from viruses, bacteria, or other infections. But in this case, autoantibodies are directed against a normal structure of the body instead of being directed against a virus or a bacteria or a fungi or other pathogens. So it is not normal to have this kind of autoantibodies in the blood. Autoimmune hepatitis type 2 is characterized by the presence of anti-liver kidney microsomal antibody and or anti-liver cytosol type 1 antibody. A very important difference between type 1 and type 2 autoimmune hepatitis is the age of the patients, since type 2 is mainly a pediatric disease affecting children and adolescents, and whereas type 1 autoimmune hepatitis affects both adults and children. What are the similarities between the two types of autoimmune hepatitis? Both affect more females than males, and both are associated with other autoimmune diseases. Other means extrahepatic autoimmune diseases not affecting the liver, and they may affect the thyroid or the skin or any other organ. And in both autoimmune hepatitis, we often found in the family of the patient someone with autoimmune diseases. And both type 1 and type 2 autoimmune hepatitis have high IgG in the blood. IgG are antibodies of the subtype G. They are characteristically elevated in autoimmune hepatitis. But there are also, of course, differences between type 1 and type 2 autoimmune hepatitis beyond the circulating autoantibodies. As mentioned, type 2 is mostly a pediatric disease and affects children and adolescents. It is often associated with IgA deficiency, which is a deficiency of another class of antibodies, the antibodies of the class A. Type 2 autoimmune hepatitis presents more rarely with cirrhosis, but presents more frequently with acute liver failure, with a severe clinical picture. What are the symptoms of the patients with autoimmune hepatitis? It is not rare that the patients do not have symptoms at all, and the disease is detected by chance while doing blood tests for other reasons or just as a checkup. And all possible symptoms of autoimmune hepatitis include fatigue, joint pain, and amenorrhea. Rarely, autoimmune hepatitis may present with the complications of cirrhosis or with an acute hepatitis in adults. Acute hepatitis, as mentioned, is a more frequent presentation in children, which also can have no symptoms or, again, non-specific symptoms like fatigue or joint pain or low-grade fever. Children may also present with complicated liver cirrhosis. What is the epidemiology of autoimmune hepatitis? How frequent is the disease? It is not very frequent. It is considered a rare disease, meeting the definition of a rare disease, which states that a rare disease affects less than 50 people out of 100,000 people. But it is important to say that type 2 autoimmune hepatitis is much more rare than type 1 autoimmune hepatitis, and is a rare, is a true rare disease, whereas type 1 autoimmune hepatitis is a frequent rare disease. How is the diagnosis made? Unfortunately, we do not have a single diagnostic test, and the diagnosis relies on a combination of factors, including the clinical presentation, so the symptoms and the story of the history of the patient, the biochemistry, the transaminase levels in the blood, the autoantibodies, which, as mentioned, are a very important diagnostic feature of the disease, Elevated IgG is also very important characteristic of autoimmune hepatitis. And histology. Histology means that we look at the liver under the microscope after having taken a small piece of liver. It is also very important to exclude other causes of hepatitis, particularly viral hepatitis, which can be very similar to autoimmune hepatitis, but is very easy to diagnose with appropriate blood tests. Liver biopsy. Liver biopsy is really important in order to make a correct diagnosis, because the type of inflammation, of liver inflammation in autoimmune hepatitis is characteristic and is typically in the form of interface hepatitis, which can be found also in other causes of hepatitis, but is typical for autoimmune hepatitis. This is a normal liver histology. This is how the liver appears under the microscope. As you can see, this is the portal tract, the so-called portal tract, where we can find a vein, an artery, and the bile duct. And the liver cells, called hepatocytes, are disposed one next to the other, and they are in a very well order. With these small white spaces here are small blood vessels surrounding the hepatocytes. And this is a liver biopsy from an autoimmune hepatitis patient. And as you can see, this is completely different to the previous slide, since we cannot recognize anymore the hepatocytes one next to the other. The architecture of the liver is disrupted. We have a massive infiltration of these small cells, which are cells of the immune system, which attack the liver cells, the hepatocytes, and kills them. A very important feature of the inflammation of autoimmune hepatitis is the high number of plasma cells. Plasma cells are cells like those one with a dark nucleus and a bright our plasma cells produce antibodies, so they are present in high number in the inflammation of autoimmune hepatitis. This is another picture of a liver from a patient with autoimmune hepatitis, where I would like to show you that in this part of the liver surrounding the central vein, there are no more viable liver cells, hepatocytes. They have all been killed by the immune system cells. And this is called a necrosis. In this staining, we can see the plasma cells, and the plasma cells are particularly abundant in the inflammation due to autoimmune hepatitis. And they are located at the interface between the lobule, which is here, and the portal tract. In this part of the liver, we find a high number of plasma cells, and this is highly characteristic for autoimmune hepatitis. Therefore, it is very important to have a liver biopsy in order to make a correct diagnosis. How is autoimmune hepatitis treated? The aim of the treatment is to achieve complete remission as quickly as possible and maintain it long term with the lowest possible dose of medications. And the complete remission is defined as disappearance of symptoms, normal blood transaminase levels, normal blood IgG levels, and negative or low titer autoantibodies, and this last criterion is used only in children and adolescents to define disease remission. treatment is based on steroids, on cortisone. And this has historical reasons, because autoimmune hepatitis was called previously chronic active hepatitis in absence of hepatitis B. And in the 70s, these patients were treated with one of the few medications available at the time, which was prednisone. And they responded very well to this treatment. And the impact of this treatment on survival was impressive, where patients treated with prednisone had a 5-year survival of 80%. But on the other hand, untreated patients had a 5-year survival of less than 25%. So this makes really a massive difference. And it is clear from these early studies that prednisone steroids have a profound impact on the natural course of the disease. So the treatment is still based on steroids. Azathioprine is often used as a steroid-sparing agent. It should not be given at the beginning because it can be toxic if the liver is highly inflamed. It is better to add azathioprine to steroids after transaminases have it is better that azathioprine is given later on when the transaminases are less high. This avoids liver toxicity. These early studies in the 70s have several limitations, but in addition to the studies, we have now 50 years of clinical experience, and we now have learned how to use steroids and azathioprine to treat autoimmune hepatitis. And it is very important how these drugs are used. At the beginning, steroids must be given at quite high doses, meaning in adults, the usual starting dose is 60 milligrams per day. But it is very important to rapidly taper the dose. In order to do this, it is mandatory to test liver enzymes very frequently, and very frequently means every week. If this is done, the dose of prednisone can be tapered very quickly, and this avoids the side effects because patients are afraid from side effects. But if the steroids are tapered quickly under strict control of the transaminase levels, the side effects are minimal. In children, the dose of steroids is based on the body weight, but the schedule is quite similar. It is important, even in children, to check the liver enzymes every week in order to taper the dose of the steroids very quickly. And again, this avoids side effects. And once the disease is under control, the transaminase levels are normal. The usual controls are the check of serum IgG every 3 months, since the levels of the IgG correlates with disease activity. Autoantibodies should be checked every 6 months. And if patients have liver cirrhosis, it is also important to perform a liver ultrasound every 6 months. With this first-line treatment based on steroids and azathioprine, up to 90% of the patients achieve disease remission, and only a minority of the patients will progress to liver transplantation. Obviously, in patients not responding to first-line treatment based on steroids and azathioprine, it is important to we try to give second-line treatments. The most widely used second-line treatment drug is mycophenolate mofetil. And if this does not work also, the patient should be referred to a specialized center for specialized care. It is also important to keep in mind that autoimmune hepatitis always responds to steroids. If this is not the case, if the transaminase do not drop on steroids, we have to reconsider the diagnosis. Maybe the diagnosis was not correct. Another important thing to be kept in mind is that in case of difficult to treat autoimmune hepatitis, it is important to look for inflammatory bowel disease, which can be asymptomatic and can be the cause of an inflamed liver. In children, particularly in children, it is also important to look for an involvement of the bile ducts, the so-called autoimmune sclerosing cholangitis. A frequent question by the patients is whether they can discontinue treatment. And according to the guidelines, the treatment should be continued for at least 3 years, 2 of which should be in complete biochemical remission. Complete biochemical remission, I remind you, means that the transaminase must be normal and the IgG must be normal. It is a good rule to repeat a liver biopsy before stopping treatment, because the liver can still be inflamed even if the blood tests are normal. At the end, we know that about 20% of type 1 autoimmune hepatitis patients can remain long-term off treatment, whereas type 2 autoimmune hepatitis patients relapse almost always if left off treatment long term. There are new drugs under investigation for autoimmune hepatitis, including abatacept, which is a monoclonal antibody used for some forms of rheumatological diseases. Ianalumab is an anti-B cells monoclonal antibody currently under investigation for autoimmune hepatitis and other autoimmune diseases. Low-dose interleukin-2 is also an interesting new diagnostic therapeutic approach to autoimmune hepatitis. A very interesting approach is the adoptive transfer of re-educated antigen-specific Tregs. This sounds quite complicated, but this means that immune system cells are taken from the blood of the patient, are re-educated, and are transferred back to the patient. And these cells are the cells responsible for the disease. And this is very specific, since only cells recognizing the antigen of the liver driving the disease are treated. And this approach may avoid a generalized immune suppression, but this is still experimental. The quality of life is an aspect of patient care which is often under-considered by the physicians. Indeed, there are few studies investigating the quality of life of autoimmune hepatitis patients. Based on the data we have, we can say that the mental well-being does not correlate with the presence of liver cirrhosis. And it has also been reported that anxiety and depression are more frequent in autoimmune hepatitis patients compared to general population. And probably anxiety and depression are related to concerns about the chronic disease, the shorter life expectancy, and the need of liver transplantation. It is interesting to see that anxiety and depression are more frequent in patients non-adherent to therapy. Non-adherent to therapy means that the patients do not take their medications as prescribed by the physician. So it is very important that the physician addresses anxiety and depression in the discussions with the patient, which are very important in order also to be sure that the patient takes the medications as prescribed. Another frequent question by the patients is whether stress, psychological stress, can induce autoimmune hepatitis. The answer is probably yes. It is well known that the immune system is sensible to psychological stress, and it has been reported that stress can induce an autoimmune hepatitis relapse, not a diagnosis, not a first occurrence, but a relapse. At the end of this presentation, I would like to mention a slightly different form of autoimmune liver disease affecting children, known as Autoimmunesclerosing cholangitis. This is an overlap of autoimmune hepatitis, mostly type 1 autoimmune hepatitis, and an inflammatory involvement of the bile ducts. This is often found in children. About half of the children presenting with autoimmune hepatitis have an involvement of the bile ducts. And this condition is referred to as autoimmune sclerosing cholangitis. It is slightly different from autoimmune hepatitis because it affects equally males and females. Despite involving the bile ducts, the liver enzymes reflecting the bile ducts damage are often normal. The IgG, which, as we have seen, are often elevated in autoimmune hepatitis, are even more elevated in autoimmune sclerosing cholangitis. And there is another type of autoantibody, often positive in autoimmune sclerosing cholangitis, which is the ANCA. And this condition is more often associated with inflammatory bowel disease, which can be completely asymptomatic. This is a magnetic resonance picture of a young patient with autoimmune hepatitis and involvement of the bile ducts. As you can see, on the left side, the bile ducts are normal, and on the right side, the bile ducts have these irregular borders, and this means that they are inflamed. So this is abnormal, and this is a diagnostic for autoimmune sclerosing cholangitis in children. According to the European guidelines, it is now recommended to perform magnetic resonance of the bile ducts in every child presenting with autoimmune hepatitis in order to exclude autoimmune sclerosing cholangitis. I would like to mention also at the end of my presentation our Swiss registry for autoimmune hepatitis now We have a wide participation of hepatology centers, both adults and pediatric centers across Switzerland. And I would like to thank our patients for joining this registry, which allows us to study the disease. We now have affiliated our Swiss registry to the European Registry for Rare Liver Diseases. And I would like to thank all the people working with me, my mentors, my collaborators, and also our patients and their families.
Thank you very much for the information and exciting presentation by Dr. Terziroli and your great personal commitment. Thank you very much, Benedetta Terziroli.
Thank you, Karina, for the opportunity to talk to our patients.